Broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. It's Jamie Upson from Stonehearth. Thank you for joining us today, where we're going to be discussing Medicare benefits. Looks like a nice day out there for those of you in the Northeast. It's pretty warm. It doesn't feel like we've entered fall at this point. I want to introduce everybody to Brian Lynch, who's our guest speaker. Just a little bit of background. I met Brian about a year ago. I was working on a case with a family out in California, and they needed some health insurance. And we have an insurance agency that we use down in Connecticut. And I reached out to them. My office does not do any health insurance, but our insurance agency that we use out of Connecticut, they help us get disability, life insurance, long-term care. And when I asked the question, I got this scenario that I'm looking to do some research on for healthcare. They put me in touch with Brian. So Brian and I met, we went over the case. I ended up learning that he knew a lot about Medicare, and that's actually what he's been spending a lot of his time on helping guide families through the obstacle course of Medicare benefits and trying to digest what all the options are. With Medicare open enrollment fast approaching, this was not on our original docket of campaigns, monthly campaigns that we were doing, but we felt that this was an important one to add, and probably one that we'll add permanently to our ongoing list of monthly campaigns for right around this time frame. I think it's important since this is going to be top of mind for a lot of people, not only those that are renewing their benefits, but certainly for those people that turn 65 and this is their first time trying to get through this. I wanted clients and guests to be better prepared about the Medicare benefits, which is, again, not a specialty that I have, and that's why I asked Brian, and he was grateful enough to and willing to join us on today's webinar. Just as a reminder, just a couple housekeeping line items. We are recording this, and Amanda will put this onto our website either later today or tomorrow. We are not doing a white paper, so this is something that's a little different because I'm not presenting it or David's not presenting it. We're not writing a white paper on this. The slides we can make available to anybody if they want a copy of them. And if you have any questions along the way within your GoToWebinar control panel, you should see in the lower section of that, if you have a question, you can just go ahead and type that in. That'll send the question directly to us. And towards the end, my colleague Amanda, who I'm always grateful that she helps coordinate these things and put these together. She does a lot of hard work for this. She'll read these off to Brian, and then Brian will attempt to answer that question. So without further ado, let me introduce Brian Lynch.
Hope everyone's well today. Thank you to Jamie for getting me involved in this. It's a topic that's kind of near and dear to my heart in terms of it's one of these things that's very similar to the health insurance world in the sense that it sometimes is made to be a lot more confusing than it actually is. I think even more so than the health side, when people transition into Medicare at 65 or they're looking at their options on an annual basis, it tends to be something that if you really break it down, it's a couple of different forks in the road in terms of the type of plan that works for you as an individual. And the pros and cons are pretty easy to kind of decipher what's going to make the most sense as an overall value to you as that individual insured. So it's always one of these things. I started getting into Medicare. A little bit more about me. I've been doing insurance in general for 13 years, and as I started to take my health insurance clients through the transition from one side of things to the other, I found that Medicare was a far stronger value and was the ability is there to get a much better overall bang for your buck, if for lack of a better way to put it, than you get on the health side. But the problem was that there wasn't a lot of good education on what the options were and why the options would be better. A lot of what you get when you're 90 days out from turning 5 or the 2 months leading up to open enrollment, you get bombarded in your mailbox. Your mailbox is full every day of literature from these carriers, but it's really kind of tough to say what is related to a supplement plan, what's related to an advantage plan. what are these carriers, offering as far as on each side of that equation. And so the goal of this presentation is to go over some of the basics. We're not going to get into plan specifics because everyone's situation, depending on what state you're in, but even further what county you're in, you'll have different options available to you. But the overall concepts are the most important thing, because that, again, most of the time for most people between Advantage plans and supplement plans, you're cutting off half of the equation pretty quickly based on preferences in terms of how things are designed. So we're going to get into the basics. We're going to get into some of the stuff that we know about 2018 and some of the timeline as far as when the rest of those changes will become evident and available to us. And then we'll work through any questions that anyone has after the presentation in terms of how all this works or personal situation. So let's go through this. This is a little bit about me. I think you get a chance to read that. It's not really important that other than to say I know what I'm talking about in this respect. No direct affiliation with one particular carrier, one particular product. Is important to know that I'm giving you basic design, but a couple of carriers that don't use brokers at all, but pretty much across the board, any other carrier I'm able to assist with, and I'm not biased towards one or the other. Again, talked about some of this 2018 data is released just prior to the October 1st, and believe it or not, some of it's released after October 1st. I'll talk about why that 10-1 data is important in a second. But it's always a little bit frustrating, because one of the things that we go into a new year with is trying to have a full complement of information. The next couple of weeks we'll make a lot of that clearer. But for now, we're basing this on some 17 stuff, knowing that there won't be significant changes into 18 as we go forward. So, let's start at the beginning before we get into timelines and specifics. Medicare is, for those of you that aren't really clear on what it is, or join the presentation to get a little more information, it's designed for people 65 or older. That's far and away where you see it the most. Once you hit 65, you're eligible for Medicare the first of the month of your 65th birthday. So that's original Medicare Part A and B will kick in at the first of the month when you're 65. Or if you're under 65, you have certain disabilities or end-stage renal disease, you will be eligible for Medicare in a lot of situations as well. And there are some sort of specifics around that we'd have to go into to make sure that you're eligible. Original Medicare includes two parts. The term original Medicare is meant to include Part A and Part B, which is to say those are the pieces that you get from CMS, which is another, it's a lot of acronyms here. CMS is the Center for Medicare Services. That's the government division that administers Medicare benefits. And so A and B are the pieces of original Medicare. If you hear that term, that's what that means. And it's broken down to those two sections, pretty distinct purposes of each section. Part A is going to be your hospital coverage. This is your major medical in the sense of like the catastrophic side. The out-of-pocket for 2017 is a $1,316 deductible. This actually says each benefit period. It's that's something I'll correct before we send the slides up. It's a per occurrence deductible, which is a little different. That's basically in the multiple hospitalizations, that deductible can be coming up multiple times in a year. So that can be sometimes if you have a frequent hospitalization type of scenario. Different, same occurrences, same type of medical issue would be a single deductible, but if you have multiple issues over the course of the year, you can hit that multiple times. Days 1 through 60, there's no out-of-pocket for that hospitalization beyond that deductible. Days 61 through 90, you have a per-day coinsurance, and then hopefully you never end up with days 90 and beyond, but if you get into that, it goes into your lifetime reserve, up to 60 days of your lifetime. So beyond that lifetime reserve, essentially those are out-of-pocket costs. If this is your first foray into one of these presentations about how Medicare works, none of this stuff should hopefully cause a panic. Wait until the end of the presentation, because we're going to talk about some of the holes in original Medicare and some of the ways we can plug those holes and make a much more sound structure. So that's one of those examples is all costs beyond that. We can have a couple of ways we can remedy that. Part B is going to be more of your outpatient services. So you look at services from doctors and healthcare providers, outpatient testing, just a lot of that stuff you see on the outpatient level. The deductible is a lot smaller, $183 per year for 17. I think that last year was $166, so there's a little bit of an increase there. you might see something similar, but it wouldn't be significant difference off of that. And then a lot of the Part B side of things is built like an 80-20 plan. So you have the deductible, that's a per year thing in this case, and then you'd have 20% of the out-of-pocket costs associated with outpatient medical care. So most of that stuff, we talk about the perceived holes, not necessarily for everyone feels that way, but one of the things people sometimes get concerned about is there's no out-of-pocket maximum on original Medicare. There's that Part A and B deductible, there's the per-day hospitalization, there's the 20% for outpatients. That's all well and good for a lot of people, as long as there's kind of a finite stopgap of that out-of-pocket. In this case, there is not. So again, something we can remedy with some of these external solutions. So original Medicare, Part A, there's no cost associated with that for most people. I say most people because most people have paid 40 quarters into Social Security over their working life. So fairly minimal requirement there, but there is a requirement. So if you get someone that just moved to the country, a short period ago, or has been, working off the table, however, you're not paying into Social Security, if you're less than 30 quarters, it's a significant premium. It might change the equation on, whether this is a good value or not. If $413 a month is going to be a Part A premium, that right away we're kind of behind the 8 ball there. If you're in 30 to 39 quarter territory, you're just below the 40, it's less. There's only at a cost of $227 a month. 40 quarters, no cost for Part A. Part B, standard rate is $134 a month for 2017. Premiums can be adjusted for that, however, based on a modified adjusted gross income calculation. And so this is an important piece because this is something people don't, oftentimes understand when they get into this and they say $134 a month because all their friends and family, whoever's already on Medicare, might tell them that's their premium. They assume it's going to be the same for them. But there are certainly exceptions here. When you talk about 2017 premium, and in our case, most of the discussion would be towards 2018, that would be based on a 2-year look back. So it's 2016 modified adjusted gross income. If you're above a certain threshold, you would pay an added premium for that Part B coverage. Now, what does that chart look like? This is essentially what that chart looked like. 2018 to be released in October, but this gives you pretty good parameters of the premiums aren't released yet, but the thresholds have been. So there's been no significant changes here for a lot of this until you get above 200K point or 107, that third tier there has been some changes to those thresholds. But you get the idea. If it's 85,000 or less as a single, or 170 or less for a couple, your household modified adjusted gross income, you're at 134 a month. If you're beyond that, it's obviously a different conversation because you have a little bit of a different cost associated with Part B, this added expense there. And again, that's just original Medicare. So this is where, a little bit of education. In most cases, a lot of the stuff, if you paid your 40 quarters and you're under 85,000 as your filing status on a 2-year look back, all this stuff is just background noise. But there are some people that do have a little bit of a different situation. It's important to speak to someone who knows the ropes a little bit or do your research to know what your costs are going to be for original Medicare, because sometimes that can drive your decisions on what you do elsewhere, if anything. Some people will look at it and say, we don't need Part B, we don't have any medical expenses, there's no reason for us to sign up for that. That's all well and good in theory, but because the government does not want to be just taking on people that have a lot of usage of their medical, they want to have the claim risk spread out. You hear a lot about this concept on the Affordable Care Act on the under 65 side. Part of the reason why they made a health insurance mandate was to ideally have healthy people pooled with people that are using the coverage more and drive that overall cost down by spreading out the claims. The same thing here. So there is a late enrollment penalty to sign up for Part B after your initial eligibility. So, as long as you have Part B, your monthly premium makes up 10% for each 12-month period you could have had Part B but not sign up for it. And then there's also a wait if you mid-year and a year and a half you decide to go into it. It may not be available because you have to wait till a general enrollment period for people in this situation. So coverage is available late, coverage starts late. Not a good idea. Obviously, the exception to this is if you have Part B, you can defer that with a on a valid basis if you have a health insurance plan provided through work, for example. So if you have a valid coverage elsewhere, you can sign up for Part B late. Your actual initial eligibility is not until that coverage is lost. If your work coverage ended, that would be your period to sign up for the Part B at that point, and there wouldn't be that late enrollment. What they're talking about here is people that don't have coverage at all and just don't see a need for it. Part A might come to them at 65 for working their 40 quarters. There's no cost, but they decide they don't want to pay the cost of Part B for any reason. It could be a late penalty, so it's important to, even if you think you may not need it, to talk to someone prior to 65 to know whether you would face penalties for not doing, the standard original Medicare. We talk about original Medicare and some of the gaps that can be perceived by a lot of people in terms of how that coverage works. You talk about those deductibles. You talk about the no clear out of pocket maximum on your costs of care on that 20% out of pocket on the outpatient side. You also talk about the lack of prescription medication coverage. So there's no prescription coverage with original Medicare. We're going to talk about that in more detail in a few slides here, but prescription coverage is important because there is a late enrollment penalty associated with that as well. So, leave it to our government, the infinite wisdom, to not offer prescription as part of their original design, but then to have a late enrollment penalty if you don't get it. So these are the things we kind of want to make sure people are educated on through this presentation, so you don't end up with a penalty out of nowhere later on. So this chart tries to detail, I talked about like a couple of forks in the road, and I think it's easier once we get through some of these late enrollment and income guidelines, and that's all stuff that we can kind of disseminate pretty quickly in the beginning. Once we get into the discussion about what are your options, it's really significant options. One's a Medicare supplement plan with or without a Part D, which is your prescription coverage, and we'll talk about how this all works in more detail. And the other option would be a Medicare Advantage plan, which is, just to confuse things further, known as a Part C plan, and that will a lot of times include the prescription coverage wrapped into it. So this is a simplified chart. We're going to go into some details on both sides of this, but this is, again, talked about the fork in the road where pretty quickly I can tell in most cases what side of this diagram is going to work for most people. Let's talk about Medicare supplements first. You'll hear these referred to as Medigap policies. It means the same exact thing. It's just a slang term for Medicare supplement. These are sold by private companies. In Massachusetts, we're looking at like United and Harvard Pilgrim and Blue Cross and stuff. They can help pay some of their health costs that original Medicare does not cover. Some of those co-pays and co-insurance and deductibles. So essentially what it's designed to do is if you have original Medicare, that's going to be the first kind of place that claims will go. And then anything that original Medicare doesn't pick up, the Medicare supplement will pick up based on how it's designed. There are only really two standard plan designs in Massachusetts, believe it or not. There's what's called a core plan and a supplement one plan. The core plan will cover, there are some, to simplify things really, it's covering a lot of the 20% coverage, but we'll still have deductibles. Whereas the supplement one plan is essentially every expense on a Medicare approved expense for medical care that's not covered by original Medicare would be picked up by the Medicare supplement. So, I'll talk as we get through the end of the Medicare supplement portion. I'll talk about some of the ways I perceive this as just a general, simplified type of look at it. But medical care outside of the U.S. will be covered by some Medicare supplements as well, which is not covered by original Medicare. And fitness reimbursement is something people look for a little more often now. That would be covered by a lot of Medicare supplements. You must have A and B to enroll, so you must have original Medicare in place to get a supplement. You still pay Part B premium to Medicare, and then you're going to pay a separate fee for the Medicare supplement direct to that private carrier. Separate expenses. These are designed to allow access to any doctor, any hospital. So if the doctor accepts original Medicare, the doctor will accept your Medicare supplement. So I run into a lot of confusion with people thinking they have a supplement and it's through this, it's through Harvard Pilgrim, and I don't know if my doctor accepts Harvard Pilgrim. It doesn't matter. They accept original Medicare. No matter who the logo is on your supplemental card, they're accepted by your doctor. Medicare supplements will not include prescription coverage. Part D is purchased separately. Again, we're going to talk about that in a minute. Premiums paid directly to the carrier. This is not, a Medicare supplement is not considered to be part of original Medicare. It's not considered to be under the CMS umbrella, if you will. So you don't pay that directly through a Social Security deduction. You would have to either pay it through an auto deduction, through a checking, or a physical check you're writing every month, that private carrier. So again, you have your original Medicare and your supplement plan. Invariably, the next step here is to look at a Part D plan, a prescription coverage, because that's going to be the one thing you'd be missing at that point from your usual medical care. So it's a standalone drug coverage. Plans can vary greatly based on what preferred pharmacies they have on a list. They might have lower costs at certain pharmacies. They might have formulary lists can be extremely different. Excuse me. You can have one carrier that doesn't have a drug that's covered on a specific drug that's covered on their formulary list, and another might view it as like a preferred generic. So there's wide variations, and what I'll do with anyone that I'm helping with this side of things is I'll get a list of medications, dosages, and frequency, and then where you go to get those medications. And we don't reinvent the wheel here. We put that into the system. It'll tell us what the costs are going to be for those medications for the remainder of the year. Or if you're looking for, during open enrollment, what it will be for the entire year for, in this example, 2018. There can be a deductible, which in this case, 2018, the cap will be $405 for that deductible maximum. Average monthly premium is about $33, $34, depending on the year. But you can have the lowest cost plans available in Massachusetts right now are about $17 a month. The highest costs are in the, I want to say some are in the $80 and change a month range. So give me wide differences. There's a little bit of a reduction in average premium coming this year, which is kind of rare to see. But based on the dollar amount you're associating with Part D, it's not going to be huge money either way. So there's up to 4 phases of coverage, and this is where people think about prescription coverage. If you've had traditional health insurance your whole life, you think about it as, what's my copays? Medication coverage on Medicare is extremely different. There's different stages. So the first thing you're going to hit is your deductible. If you have a deductible that applies to your Part D coverage, that's going to be the first thing you hit. Some plans, a lot of deductibles only apply to certain tiers, but no matter if there's a deductible on that tier, that would be the first thing you pay. Then there's the initial coverage stage. The initial coverage stage is indicating that type of thing you might be used to. Copays, different tiers of copays based on a preferred generic, a non-preferred generic, a brand name, a specialty drug. You can have all those different tiers. And you can obviously have prescriptions that are covered in any tier, and that would be the exceptions we'd look up in advance of signing up for a plan. Once you get to the point where your total drug costs reach $37.50 for 2018, you go to the coverage gap stage, and this is always a hot button topic. This is what people will commonly refer to as the donut hole. So, a lot of you might have heard that term. This is what it means. Basically, once you're at $37.50 in total drug costs, you pay 51% of the total, or 40% for generics, or 40% for brand names. No more than that. But the costs for those medications can be higher. Now, if someone has basic generic medications or no medications at all, this is sometimes a non-issue. But it's still important to know that, if you do have a change in medications and you all of a sudden you do hit the coverage gap halfway or 3/4 of the way through the year, that you will see an increase in your cost for your medications. It's for a short period, however, because once you go from $37.50 to $5,000 for your yearly out-of-pocket costs, your personal yearly out-of-pocket drug costs, you pay 5% or $335 in 2018 for generics, or 5% or $8.35 for brand names. So there's actually 4 stages to the Part D coverage. Assuming that drug is covered by the plan, it can fall into any or all of these stages throughout the course of the year. And that's why it's important to, sometimes again, I talked about the value of Medicare versus health insurance. Sometimes one of the biggest places that value can blow up is on the prescription. That's why, it's such a small piece of the monthly premium overall, but it can be the most important component, because this is where the most significant out-of-pocket costs can stem from. And if you have a significant list of medications, this is where we're going to thorough vetting it out in advance to see what the options are, and so you're basically prepared on what your costs might be in different stages of the year. Talked about the late enrollment penalty on prescription coverage. Essentially, the late enrollment penalty is if you had a 63-day or more lapse of not having Part D coverage after your initial enrollment period is over. So it's Part D or prescription through a Medicare Advantage or a medical health plan through your employer, for example. Some sort of creditable coverage. If you did not have that, you essentially pay 1% of the national-based beneficiary premium, so national average, times the number of uncovered months without Part D. So that means if you had a one-year cycle where you're eligible for Part D, you did not get it, and you decide to pick it up later, you'd have a 12% increase based on that national-based premium over the cost of your plan, and that'll be paid as long as you have Part D coverage. So it may not be much of an issue. You say 12% of these smaller numbers is going to be minimal, but it's adding costs for the entire rest of your life that you're on a Part D plan. And really, the only time that you see a Part D, this penalty not factored in is if someone's never going to get Part D coverage. Like if you had coverage through the VA, or you had there are other limited, very limited, a small part of the population that might have creditable coverage elsewhere for medication. You want to have a Part D if you're not in that group, and that's something that we can certainly vet out as well. There is an income adjustment on the Part D as well. You talk about those same thresholds. This is a 2017 chart that shows your yearly income based on 2015. So again, very strange. They do a 2-year look back. On the initial stages of retirement, sometimes you can have a higher threshold of your costs for plans like this, and then it gradually will phase out. If you get to 2019 and you retired 3 years prior, now that adjustment goes away and you're back to the base plan premium. This is recalibrated every single year, and there might be an adjustment based on your income at any point, any specific year, I should say. So we talk about the acronym soup here. These are another couple you'll hear. ICEP is initial coverage election period. So this is when you're newly eligible for Medicare. You're a 7-month period, 3 months before, so 90 days prior to your Part B effective date, the month of, and then 3 months after. So that's in most cases, unless you're delaying Part B, but you have that 7-month threshold. I usually recommend if people are aging into Medicare that, we try and take advantage of that full 90 days and get in touch, just talk about the timeline of steps here as close to that 3-month window prior to age 65 as we can, or, eligible elsewhere under 65 if there's a disability involved. Initial enrollment for Part D, just to confuse things more, is called IEP instead of ICEP, and that's when you're first eligible to enroll in Part D plan. Most of the time, this is the same date, but there are exceptions. Again, if you have prescription coverage provided elsewhere, that might be a different date. Most of the time, it's the same day. So that's essentially one half of the equation. That's a Medicare supplement, and I sometimes refer to that as kind of the set it and forget it approach. It's taken from the old infomercial moniker there, and it's the idea that you're going to pay for a plan that covers you wherever Medicare is accepted, and you go with a more robust version, we'll cover you on all Medicare-approved expenses outside of your medications. You're going to pay more monthly for that type of solution. But if people just want to have kind of that worry-free type of approach, you don't have to worry about network restrictions. You don't have to worry about out-of-pocket exposure on the medical side. A Medicare supplement can be a great fit for that. The flip side of this is Medicare Advantage plans. So these are Part C plans, and I don't see that moniker used as much anymore because it gets a little bit confusing with Part D being medication. So just refer to it as Medicare Advantage. They're offered by private carriers as well, but they're actually considered to be more under the original Medicare umbrella, under the Center for Medicare Services tutelage here. So whereas a supplement plan is meant to be in addition to original Medicare, an Advantage plan is meant to be a replacement of original Medicare. So the care and administrative tasks are managed by the private carrier that you sign up with rather than the federal government, CMS. So the carrier is then paid a stipend by the government to provide you those services. And what that does is, it kind of gives them the ability to charge less to the consumer because they're getting the payment on the backside from the government for administering the care for that insured. So taking the burden off the government, they're paying the carrier to do that. The premiums can be as low as $0 additional beyond your Part B premiums for some of these Advantage plans in some counties, because the carrier is getting that payment from the government. They're going to design the plan so they don't have to charge any more to the insured. And so these can be pretty attractive for people with either a limited budget or limited usage of the plan, where they don't mind more out of pocket as you use it, but they want to keep that monthly cost lower. These can be an attractive offering. The Advantage plans are obviously designed very differently, but they must be equal to or better than original Medicare. So you're not going to lose anything by going to an Advantage plan that you had when you had your coverage through original Medicare. Most of them will actually offer extra coverage beyond the health, with vision, hearing, dental. That's not the case across the board, but there are most plans that will offer some value-added services. One aside here, when you talk about the stipend they're paid by the government, I talked about your mailbox being full every day for the 90 days leading up to Medicare eligibility. Most of that is going to be related to Medicare Advantage plans, because this is where the carriers are seeing the better advantage on their side, is going to be to get you in a Medicare Advantage plan. That's where sometimes, insured Medicare individuals or people that are going to be eligible for Medicare can get confused, because there's going to be a lot of information in their mailbox from these private carriers touting all their different facets of care, but it may be all related to Medicare Advantage, and they're not really sure how that relates. You may not see much from the supplement side of things. So keep that in mind as you look at some of the literature that might come in the mail. It may be giving you a much more skewed story towards this side, and try and give you more of an impartial story on some. A supplement works well for some, and Advantage works well for others, and there's no right or wrong answer. It's just different solutions. Various types of network designs on a Med Advantage. Talked about this being built more like a health plan. You are going to have a network for that specific carrier you obtain coverage from. So it's not going to be the type of thing like a supplement where it's accepted anywhere Medicare is accepted. On an Advantage side, it's accepted anywhere that particular carrier. That's very different. You have to make sure your doctors and your hospitals that you want to make sure you maintain access to are in that Advantage plan network if you want to go that direction. And the other thing that's in the smaller font here is coverage may not be available out of your home state depending on the carrier and plan design. Some carriers have developed more of a national network and different creative ways for you to access that network. Some carriers only give you access inside of your home state, so it's important to make sure you're clear on what you get and what you don't. Most Advantage plans will include Part D coverage, which is the prescription side of things as part of the plan. But again, there are different designs within the plan, same way there are for standalone Part D, so it's important to verify what your cost is going to be with that particular Part D embedded type of coverage. The exception to that is there are some plans that are offered Med Advantage with no prescription coverage, and those, again, designed for people that have a VA plan or something elsewhere that gives them that creditable coverage. These plans will vary greatly in terms of deductibles and copays or your out-of-pocket exposure in different areas. Again, just like a health plan would, all the way up to 65, you have different monthly premiums associated with the lower or higher out-of-pocket maximums, and how those benefits are designed is something that, that's why it's important to kind of go to more of an impartial source and get some of these variations so you know what's going to work for you personally. Provider networks, plan designs, and premiums can change each year, as well as obviously your health needs and your budget. So I recommend it to kind of revisit that decision annually. We'll go over the timeline in a few slides, but that's where this open enrollment idea comes into play. Is if you're not 100% happy with the plan you have, and you're not 100% happy with the adjusted premiums or benefits for the following year, you can look around and see what's out there. On the Med Advantage, just one last note here: these premiums can be paid via check or EFT like the supplement, but unlike the supplement, they can be also done via Social Security deduction. If you're taking Social Security, you can run the Med Advantage. And actually the Part D coverage as well can be run through your Social Security, where it kind of is taken out before that check even gets to you. And some people like that because it just takes all the maintenance out of it. In terms of the timeline, again, we talked about this October timeline. The reason why Jamie and I, discussed the idea of having this webinar in late September was to get in front of all this stuff and make sure you're clear on what your options are. So October 1st is when plan reviews begin. What that means is that from October 1st to October 14th, you're able to discuss plan options with either, a carrier directly or with myself or anyone else who's a licensed broker. So from the 1st to the 14th, you can talk about plans, but you actually can't sign up for a plan. It's kind of like a cooling off period. You get to review your options, but you actually cannot submit an application even if you want to. That program of actually applying for coverage starts on October 15th. So this will run from October 15th to December 7th, which is when you can talk about, apply, whatever you need to do with your plan. That's the period to do it. Anything you do during that period will take effect on January 1st. So just because you sign up for a new plan in November, don't disregard that old plan because that's still going to be your coverage for the rest of the remaining calendar year. You can enroll or disenroll from a Medicare Advantage plan. You can, go from Medicare Advantage plan back to original Medicare, sign up for a supplement plan. You can sign up for a Part D plan if you missed your window initially. This can all happen during open enrollment. One important note down the bottom there is if you apply for a plan early in open enrollment and you see a different plan that you like better and you weren't aware of prior, if you apply a second time, the last enrollment request received is honored. So, this doesn't happen often, but it's important. Someone says, what if I make a decision October 15th and I regret my decision? You can go back to the drawing board and we can get a different plan before December 7th. That last enrollment request is the one that they look at as valid. Outside of open enrollment, the biggest thing you see is you need a special election period, which means that a period outside of open enrollment when you may elect or change your plan. And obviously the biggest one here you're talking about a special election period is when you age into original Medicare, that IEP, that original initial election period. This SEP, special election period, is beyond that. You're talking about moving from one state to another, or even within a state, maybe one county to another doesn't offer the same network for you or the same offering. That's a qualifying event to switch. Involuntary loss of drug coverage, a carrier might say that they're no longer offering plan. They give you a run-up period to look around and find another option. Or they might say that your particular medication, one medication that you take that's expensive, that carrier is changing their formulary list, they're not going to cover it. We can look around and find something else that's a qualifying event to do that. Gaining or losing Medicaid or gaining or losing a subsidy, they allow you to kind of reassess that on a new perspective on your budget and go find a different plan. You talk about making, regretting your initial decision during open enrollment, signing up for a second plan. That's all well and good. If you sign up for a plan and you go through to January 1st and you get onto it and it's just not working how you wanted it to, you can disenroll from a Medicare Advantage plan on January 1st to February 14th. At that point, you can return to original Medicare and a Part D plan. You can look at supplement plans and maybe add that as well at that point. Again, this is another one of those things where maybe speaking to one person out of 100, it becomes an important piece. But just knowing what your options are, knowing what the timeline is, it's important to have in this presentation to know that there's a lot of checkpoints here to make sure that you're making the right decision as far as your coverage. Involuntary disenrollment. If you do want to keep your plan, but you moved outside the enrollment area for more than 6 months, or you lost your entitlement to A or B, or a plan is terminated, you're going to have to disenroll now whether you want to or not. So again, these are the 1% of the population crowd here that wouldn't do it on their own, but that would become something where you'd have to, go back to the drawing board and figure out what you're off. That's essentially it on the Medicare side. Obviously, we're going to take questions, and Jamie, you can speak a little bit more about some of the upcoming webinars you have. A lot of info in the last, 22 slides. I talked in the beginning about how simple Medicare can be if you have the right guidance, and I believe it or not, after all that info, I still do truly believe that. For me, it's a lot of the stuff we go over during this presentation is, you have to get into the conversation to make sure people are fully educated. But when you actually break it down and you think about the percentage of the population that can disregard some of those income tables, can disregard some of these special periods for certain segments, it really becomes a couple of different, decision trees, a supplement or advantage plan, and which carrier offers the plan that you want. So what do your prescription costs look like? It becomes a very simple conversation. And I think with some of the bombardment of materials you get in your mailbox, and some of the stuff you see online or on TV, and some of the conversations you have with friends and family, it can just get really confusing. And the important thing is to understand is everyone's options are different depending on where they live, what their income is, and what their medical situation is. And just talk to someone, or do a lot of research on Medicare.gov, or talk to someone like myself to help guide you through this process, because it'll be a lot easier than some of that communication can make it out to be.
Good, excellent. Thank you, Brian, for that. So just again, a couple of housekeeping line items. If anybody has any questions, you can just go ahead and type it into the GoToWebinar control panel. Quick update, tomorrow we're hosting another webinar on college planning, where David Giuliano is going to be presenting. David's actually traveled the country giving presentations on college planning. I've seen his presentations, so if you or a family member are going to be needing to address college expenses in the near future, or even in the next couple of years, it's one of those things that you probably, if you plan early, it usually requires fewer changes, and it's usually advised as early as you can plan for that stuff. So I think people will like that presentation. We added a new green option for clients that have our diversified portfolios, and on Thursday, October 12th at 11 a.m., Chris Gothiers, our CIO, is going to be presenting on what we call our carbon light portfolio solution. Later in the month, October 19th, I'm going to be presenting on estate planning. Estate planning is a consistent request from clients. It's something that we I would say almost in every meeting or every other meeting, it's a topic of conversation that comes up anyways. So this is always a popular event. And finally, we added and are going to, on a regular basis, which I think it's going to be quarterly, actually it says quarterly right there, our CIO, again, Chris Gothier, is going to be giving updates on what he sees in the marketplace portfolio. So as a reminder, if you want to sign up for any of those, just go to our website. You can click on the link for those that you're interested in, and it will automatically sign you up and send you an email with login instructions, plus a couple of reminders as the date fast approaches. So now I'll turn it over to Amanda if anybody has any questions.
Hi, Jamie and Brian. I do have a couple of questions here. The first one is, how do I know if I should go with a Med Advantage plan or a Med Sup plan?
So I think the biggest thing there is just what does your health look like? What does your budget look like? But beyond that, what's your personal preference in terms of how you like things designed? Some people would just rather pay a higher monthly premium for the supplement type of design, and have less concern or potentially no concern about out-of-pocket medical expenses coming up when unexpected things occur. And then, the other thing is, do you want to have that universal access to every doctor, every hospital? If you do, then the supplement plan is a much better option for that. The Advantage plan would be more geared towards people that have a desire to keep their monthly costs low, and they're okay with having a restriction as long as they vet out their specific doctors and hospitals and they're in there, they're happy, and they just want to have something that's going to keep their monthly costs reasonable and give them that, fill in some of those extra gaps that original Medicare doesn't do. Give them a prescription plan, give them a defined out-of-pocket maximum, and pay very minimal monthly in a lot of these plans to do that, and just have a little bit more of a comprehensive solution beyond original Medicare. That would be for people that have that kind of preference.
The next question we have is, I have no medications. Is there any way to avoid having to get a Part D plan?
You cannot get one. That's certainly fine. That's well within your rights to not. But again, we go back to that slide. We talked about the penalty that is associated with late enrollment. And if you talk about that, you got a 1% penalty for every month, 1% of the national average premium for every month that you're without Part D. If you elect to get it later, and you pay that penalty for the rest of your time you have Part D, so potentially the rest of your life you're paying extra for prescription because you didn't get it initially. a lot of the lowest cost Part D plans are going to be very reasonable to avoid that penalty, and you know, a lot of people, truthfully, that's the only reason they get it, is to avoid the penalty. So that's an option that's available, is looking at what's the cheapest plan available in your area, and if that meets your needs and you're going to satisfy the requirement, that's the direction we may go.
The next question is, can you just confirm the open enrollment start date? We have a client that's heard both dates, October 1st and October.
Yes, I think, you know, when you talk about that, you go back to that screen here, if I can find it. You know, October 1st is the day you can start looking at options. You know, before, like say today, if someone wanted me to look at 2018 options, truthfully, for some of these carriers, they're not even released yet. But beyond that, I can't even do it based on Medicare restrictions. Once October 1st hits, we can look at options. And then once October 15th hits, you can start signing up for options for next year.
What if I select a plan I don't like? Do I have to be on it for the whole year regardless?
So there's a couple of ways around that. Number one would be, you talk about the enrollment period. That, you know, if you're dead set unhappy, I mean, my contention would be, if you're doing the right research and you're having the right discussions prior to signing up, that would almost never happen. You know, obviously, minor exceptions if there was a drastic change in health or budget, I guess that could happen. But for the most part, it's going to be extremely rare to have to take advantage of that. But that would be one way to get out of a plan if you were on it. You have that month-and-a-half window at the beginning of the year. After that, it would have to be more of a special election period. Say you lost coverage at work because you left a job and then you took another job that had health coverage. You could basically go out of the Medicare system and then back into it when you left the job again. You know, there are slight exceptions that I advise. That's more of a like case-by-case type of question that, you know, most of the time the answer would be, you know, you would have to keep that for the year, but a lot of times it's not the case. I mean, you'd have special election, disenrollment, and you'd have obviously the ability in some cases to just, you know, drop plans, but it's not something you want to lightly. You want to talk about the pros and cons with someone that knows some of those concerns.
Okay, it looks like this is our last question. It says, I currently have health insurance provided through work. Will I be penalized if I do not move to Medicare at age 65?
No. If that plan is a creditable coverage plan, which of course most group plans would be, you would not be penalized, and you know, you would have a special election period of Part B. You know, Part A is kind of coming as a rite of passage to turning 65, and that would be provided to you regardless, but then you're electing to either take Part B or defer Part B. And if you do have coverage through work, you could defer Part B, and then when you lose that coverage through work, you have that qualifying event to give you a window to elect to take a new plan.
Okay, it looks like that's it.
Excellent. Amanda, thank you for those questions.
Sure.
Brian, thank you again for presenting to us on the Medicare benefits. If anybody wants to reach out to Brian, Brian, do you have a website that they can go to?
Yeah, the website is lynchinsurancegroup.com. So that'll give you a summary of what I do, both Medicare-wise and beyond. My phone number, which I should have put in here, and you can obviously reach out to Jamie, and he has it. Otherwise, it's 781-405-5225. And my email address is brian@lynchinsuranceGroup.com, BRIAN. So plenty of ways to get in touch, but if you didn't write any of that down, you forget any of it, certainly Jamie can be your first point of contact.
Excellent. Well, that concludes our presentation. So thank you again, Brian.
Yeah, thank you.
All right, everybody take good care.